Hello, everyone. Thank you for joining today's webinar called Improving Care for Patients with Disabilities. My name is Alex Green, and I'll be the moderator for the session today. I'm an internal medicine physician and one of the co-founders of Quality Interactions, an organization dedicated to improving healthcare through effective communication and compassionate care for everyone. For those of you who aren't able to see me, I'll describe myself briefly. I'm a middle-aged white male with short, dark hair, with a lot more gray in it than there used to be, wearing a blue button-down shirt and a blue jacket. I served for many years as associate professor of medicine at Harvard Medical School and as the associate director of the Disparities Solution Center at Mass General Hospital. And at MGH, one of my main research mentors was Dr. Zary Amirhosseini, who is one of the world's experts on healthcare experiences and outcomes for persons living with disabilities. I now work in do my clinical work at a federally qualified community health center in Worcester, Massachusetts. Today, I'll be hosting a discussion with a leading expert on delivering services to patients with disabilities, Zary Amirhosseini, who is Disability Program Manager at Massachusetts General Hospital. And while we won't be able to take live questions during the session today due to our fairly short time, we have about 30 minutes, we'll address some of the questions that were already submitted during registration, and we'll be happy to follow up with folks by email to address any additional questions afterwards. We'll also send along relevant resources following the presentation to support your learning. Also, closed captioning is available. Just click the CC button in your toolbar. And I should mention the session is being recorded and will be emailed out to participants after the presentation. So, Zary, welcome, and thank you so much for joining us today.
Thank you so much, Alex, and thank you for this kind invitation. Um, so before I start, just a little self-description. I am a middle-aged woman, short brown hair, blue shirt with a white background, quality interaction background. And I identify myself as a person with a disability or a disabled person, either one. I am a wheelchair user. I was born with muscular dystrophy. So I am my disability is part of who I am, and that's how I identify. So thank you very much. And just as a background, you want me to just kind of.
Yeah, why don't you tell us a little bit about yourself, in addition to what you've already mentioned, which I appreciate, and your role at Mass General Hospital as
Mhm.
program manager there for disability, and the kinds of programs that you've worked on.
Sure. So I've always been an advocate, especially because I was born with a disability. I have a very, very as high sense of belonging to my community and advocating for my community. So I started my work as an advocate while I was an undergraduate at Pittsburgh State College in Pittsburgh, which was a very inaccessible university by buildings. I had all my classes were in one building, and when they were in other buildings, they would have to be moved. So the sense of the idea that I always had to advocate for myself was there already. But then I also, as when I graduated, my first job was at Boston Center for Independent Living, which, if you're not familiar with it, is a independent living center that caters to individuals with disabilities who want to live in the community independently. And what they do is basically support individuals with learning how to live in community, whether it's using transportation, looking for housing, employment, etc. So I think that my first real interaction into what it was like to be really an activist was during the passage of Americans with Disabilities Act. I actually participated in what is called Capitol Crawl, which was prior to the signing of the ADA, where thousands of people with disabilities marched from the White House to the Capitol building And some of us got arrested that day under civil disobedience. But this was actually an important part of how we advocated for Americans with Disabilities Act in 1990 to be passed. So this is my background. This I'm very passionate about it, and I think this is a good introduction to who I am as a
Thank you.
person. Um, my career, I've always worked with people with disabilities. I studied my degrees in psychology, but um, I had already made a decision that my goal, my work was around working with people with disabilities. So I worked in higher ed. I worked at Harvard University. I worked at UMass Boston with college graduates. And then this position opened up in Mass General, where I had the opportunity to advocate for people with disabilities in healthcare. And because of my own background as a patient, I knew how important and valuable it was to kind of go into this position knowing that I was coming into it with my own personal experiences and how much value I could bring into the position. So, and the way the job was actually created, and I always like to tell this story a little bit because it's really important for people to know why I'm even there. Three of our patients at Mass General and Brigham and Women had filed a complaint against the two hospitals because of lack of access to accommodations. So, as a result of that, Boston Center for Independent Living and Boston Legal Services agreed to enter what is called a memorandum of understanding, which is short of getting a lawsuit. And basically, what it was a 6 year agreement between the two hospitals and the community to kind of look at four areas of remediation, and I will tell you about that. But basically, they agreed to kind of over the 6 years look at all these areas and see how they can improve on the issues that these patients had brought up. The four areas that we were looking at were architectural remediation, adaptive equipment, medical adaptive equipment, policies and procedures, and training for staff. So those were the four pillars of my work. As far as
Fantastic.
the program that I provide services, we can talk about that, but I'm sure you can follow up.
Yeah. Yeah, I'd like to get into those four pillars in a little bit more detail. Let me first just ask you to kind of set the context here a bit. October is National Disability Employee Awareness Month, as you know, and some of you out there may know as well. So we've timed the discussion today to really highlight the importance of that issue. Not just this month, of course, but really as an area to be focused on throughout the year, which is actually exactly what you're doing at MGH. So we'll talk more about that. But I thought as part of today's discussion, I really wanted to raise some of the questions and reflect on what many of us want to know as healthcare professionals about disability, how it impacts our patients' lives, their healthcare interactions, what we can do to provide better care for our patients living with disabilities. And we've tried to splice in some of the audience members' questions as well into the questions that I'll be asking you. But first and foremost, it's important to really consider the concept or the word disability and clarify the population of individuals that we're talking about. For example, when I thought of disability many years ago as a physician just starting out, the first image that would come to mind was a person who uses a wheelchair due to a physical disability of some type, like paraplegia or multiple sclerosis or muscular dystrophy. But to set the context for this whole discussion today, it's important to try to broaden that perspective, as I'm sure you would agree. So maybe you could tell us a little bit more about this population of individuals we're considering, those who live with disabilities.
That's a great starting off question because disability by itself, there is no one specific definition for it. It's so complex that if it depends on which perspective you look through, which lens. Obviously there's a legal lens, which is under Americans with Disabilities Act, Civil Rights Act. There is also the government lens, which like the World Health Organization, which really defines disability as interaction between an individual's impairment and the environment and the barriers in the environment. There's also the self-identity and the definition of what disability is to the individual. Some individuals like to describe themselves on a person language, and then some as disability identity language. And I will talk about that a little bit later. Um, so I think that one of the things that, like you mentioned earlier, is that that perception of disability has always been around mostly visible disabilities, whether it's around seeing someone who's blind or deaf or someone in a wheelchair.
Hmm.
But one of the things that unfortunately we haven't considered or looked at is non-visible disabilities. For example, mental health conditions, cognitive, neurodivergent individuals. So I think that it's important to, when we talk about disability, to think that disability doesn't just apply to one set of individuals, but in fact, it, it's a range of individuals. And as you're getting older and the medical technology is getting better, older generations are going to have even more disabilities. I always joke and say disability is the only community that eventually all of us will belong to. So whether you have a disability or not now, eventually you might have a disability as you get older.
Hmm.
So, and then the other thing is that disability is not always the same to everybody. So, in other words, um, some people may not identify with one group, but may identify with others. So, for example, we have some patients who have physical disability and also, for example, deaf, but they identify with the deaf community. And so they identify themselves as being deaf, but not physically disabled, because that's how they see and perceive themselves. So I think it's important when we talk about disability to really ask the individual how they like to be identified. And that's, I think, the most respectful way of communicating and understanding disability, by asking the individual and their loved ones.
Oh, yes, completely understand that. And that's really the patient-centered side of this, looking to what the patient or the individual identifies and how they identify. So, of course, you've made it very clear that the concept of disability is very broad, very diverse, and turns out to include a very large proportion of the patients that we end up serving in healthcare. And obviously, this is going to affect different people in different ways. Maybe you could give us a little insight of some examples of the way that the healthcare system oftentimes falls short when caring for patients with living with disabilities of various forms.
Sure. So, of course, healthcare has indeed faced various challenges and shortcomings when working with patients with a variety of disabilities. And I'm just going to give you some things that I've dealt with while I've been at MGH. And
Hmm.
one of them, of course, is first and foremost is lack of accessibility, whether it's physical accessibility and receiving care as far as, for example, getting into the buildings, ramps, elevators, whatnot, accessible medical equipment, high-low exam tables, wheelchair accessible scales, or whether it's programmatic accessibility. For example, are we able to manage complex patients who need a variety of disability outside of what is known as what we perceive to be usual accommodations?
Hmm.
Um, and then communication barriers is another one. So we have a lot of our healthcare providers who state that they do not have adequate training in how to communicate with patients who have disabilities that lead to misunderstanding and inadequate care. For example, language barriers or lack of sign language interpreters and inaccessible information that might contribute to these issues. For example, if someone needs information in an alternative format, again, that might contribute in understanding the information that's being given to them. The other is the limited um, provider knowledge and training. I feel that that's really first and foremost, the important piece of the puzzle. That if the providers don't have the basic knowledge and training to be aware of the resources, b how to communicate with patients with disability, and see the compliance around providing accommodations for people with disabilities. Um, the other one is bias and discrimination. So we all, of course, have our own biases, whether it's implicit or explicit bias. But of course, I think one of the most important things is to really kind of test our own implicit bias and see where we might actually need to kind of strengthen our 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 knowledge of what's best, how to best work with people with disabilities. The other one is
Could I
financial.
pause you for 1 second on that? Because that's such an important topic, and I just wanted to see if we could drill down a little deeper on this concept of bias and some examples of the types of assumptions that healthcare providers oftentimes make about patients with disabilities that lead to trouble or lead to difficulties in some way. Are there some examples of these assumptions that I know that for example, have made assumptions about people, then realized that they were incorrect at some point and worked to try to fix that in my own thinking. What are some examples? What kind of biases do patients oftentimes deal with when they're living with disabilities?
Sure. So I think some of it has to do with providers assuming incompetence
Hmm.
of patients with disabilities, not being able to make their own decisions,
Hmm.
ignoring other health concerns. For example, providers may focus solely on the disability and overlook other issues that the individual might be facing.
Right.
Um, Overestimating disability impact. For example, providers may assume that a disability significantly impairs a person's quality of life or ability to function without fully understanding the individual's capabilities.
Hmm.
Um, and then underestimating pain and symptoms. A lot of times, what happens is providers underestimate or misinterpret pain and symptoms that the individual is trying to describe, and they kind of base it on the disability rather than the actual condition that's presenting to them.
Hmm.
Then generalizing experiences. Again, I can't emphasize on this enough that healthcare providers usually generalize experiences among individuals with similar disabilities. And so they say, oh, if person A has autism, and they experience this, and person B is probably needing the same type of accommodation and experiencing the same thing, which is not true. And then finally, assuming lack of compliance, for example, a lot of healthcare providers assume that individuals with disabilities may be less likely to follow a treatment if they're given that opportunity, and that's not the case. And one final one, and I think this is one that's also huge, is neglecting mental health. A lot of times we don't talk about mental health amongst people with disabilities. And I'm not just talking about people with psychiatric disabilities,
Hmm.
but people who have other disabilities. And mental health is a secondary disability that is not actually assessed during the visits.
Yeah, that's so important. And just to kind of bring my own experience into this a little bit, when I was doing a lot of clinical teaching of residents, I remember a resident telling me that they were doing a first examination on a female patient who was 21 years old and who used a wheelchair and had been using a wheelchair most of her life. And when I asked whether, we've got either the resident did or was planning to do a gynecologic examination, it was not on their radar screen. So, well, with gynecologic examination, this, it's going to be difficult because the patient's in a wheelchair. I don't think they're sexually active anyway. Well, did you ask about that? We need to do that, and I remember specifically having this conversation about, is there an assumption here that should not be made? And that's just one example, but that pervades throughout the clinical care pathways that we have. So these are really important issues for us to think about as we're considering our own personal biases and how we make assumptions about patients based on their disability.
And just one thing that I really want to highlight, you triggered something in my mind, which is actually we have a higher rate of cancer among people with disabilities, especially breast cancer, colorectal,
Hmm.
and there's another one that I'm forgetting now. But that's because physicians often don't think about preventative care, or they feel like something might be too difficult for a patient
Hmm.
or not accessible. For example, mammography. Most physicians think, oh, well, maybe the mammography machine might not be accessible or easy for someone in
Hmm.
a wheelchair, or colorectal exam might be too difficult as far as preparation.
Right,
But in
right.
fact, what happens is as a result, a lot of people with disabilities are diagnosed with cancer because of it.
Yeah, or diagnosed late.
Yep,
Uh, so quickly, I want to touch on one topic, which maybe not everyone's favorite topic, but I think important to bring up, which is the regulatory landscape about disability. I don't want to spend too much time on this because I want to get to some of the solutions aspect of things as well. But maybe you could just mention some of the regulatory issues that we need to be thinking about in healthcare around disability.
sure. So for the past 50 years, any medical institution that has received federal grants is obligated under 504 Rehab Act to ensure that there is a non-discriminatory practice and that individuals with disabilities have access to medical care. However, what happened is, um, in addition to 504, Americans with Disabilities Act in 1990, and then Chapter 1557 of Affordable Care Act came into picture to even reinforce that to other areas that were not federally funded. So, but what has happened though, unfortunately, with all these laws in place, people with disabilities still experience disparities. So recently, actually, one of the most exciting things that has happened is a new ruling through Department of Health and Human Services to kind of put a little more teeth into the push for making sure that people with disabilities have access to medical durable equipment and also
Hmm.
staff training to be able to use these equipment. So
Hmm.
I think that hopefully by having this law updated, it will push all the physicians and the healthcare providers to make sure that everybody provides accessible care.
Absolutely. So,
Yeah,
so important to make sure not only that we want to do these things, but also that we're in a system that is making it important and necessary for us to do these things. So, uh, wanted to get to the solution side, understanding this is obviously a very complex topic. There's many ways we can address this and that we have to address this, but just again, some examples of ways that we may think about as healthcare professionals to improve care that we provide for patients with disabilities. And if you want to also mention some more systemic one, we have about 5 minutes left. We can talk a little bit about that as well.
sure. So I think when we talk about what are some of the good solutions, is to just think about person-centered care. And what person-centered care really means to me is creating several avenues of first providing individualized care plan for people with disabilities so that each patient we can take into their account of their abilities preferences, and goals. So creating an individualized care plan right at the start of us assessing a patient's needs is really important. Respect for autonomy. Again, I think I've mentioned that before, that um, respect the autonomy of each patient by involving them in the decision-making process related to their care, and also involve their family and caregiver and support persons in that conversation and decision-making process. Effective communication, again, make sure that you're aware of what is the best way to communicate with the patient, whether that it means making sure that there's an ASL involved, or if a patient has adaptive communication devices, that you allow them to use those devices. So effective communication, obviously. Training and education, again, very important. Um, Inclusive practices. So one of the things that I always like to say is that providing care for a person with a disability is very complex sometimes, and really making sure that we work as a team with other areas so that a patient with a disability is not just getting their care from just their physician, but other areas that might be able to provide support for that patient. Um, and that's it, I think. And then, of course, most important, regular feedback and evaluation on how we're doing.
Exactly. So important that we keep this perspective patient-centered as best as possible. And that's what we've tried to do in all the work we do around cultural competency and disability awareness, is make sure that we're asking patients for their perspective and keeping it very patient-centered. Zary, thank you so much for being with us today and sharing some of your insights from your really impressive work at Mass General Hospital. And I know you were instrumental in the design of our most recent course release from Quality Interactions. It's entitled Disability Awareness and Person-Centered Care. We're very excited about this course, which we recently redesigned. We're putting up a few slides here, a few screenshots, so you can see how interesting, engaging, and interactive this course is. It's not one of those check the box courses. It's actually quite engaging and really fun to go through. It includes a section on best practices for working with individuals who have autism or who are neurodiverse. So that's a new section, as well as more in-depth presentations of ableism, bias, and disability etiquette. The course provides population health data and a clear, actionable presentation of ADA, the American with Disabilities Act compliance in the healthcare setting. And through the end of November, we're offering a discounted rate of $25 on the course. So it's really a great time to check out this newest of our Quality Interactions course offerings. You can, of course, find us online at qualityinteractions.com or download the materials available here for more information on how to demo the new course. And we'll also be emailing these materials out to everyone who registered for the event, including also a helpful tip sheet around disability etiquette. So we've run out of time, and I think we kept it pretty tight. So thank you all for joining us here today. I hope you have a great rest of your week, and thank you again to Zary and for those of you from Quality Interactions who helped put this all together. Take care. Bye-bye.